Good afternoon. It's a pleasure to be here to deliver an 8-hour lecture to you in about 1 hour or so. So I'll see what I can do about going through this. And just to put a little bit of perspective on this, I started working in the criminal justice system in 1989 as a result of a class action lawsuit in which I testified, and the sort of response to that was, well, all right, so you've identified that we've got some serious problems in our prison system, and now can you try to do something about it? So not only do I wear my doctor's stethoscope and go into the prisons and see patients, but I've been thinking for a long time about how to create interventions that really improve the lives of people living with HIV who cycle into and out of our criminal justice system, and that's not only domestically but internationally. So let me just set the stage for here in the U.S., but in many places throughout the world it is not that different. But in the past 30 years there has been a 300% increase in growth in our criminal justice system, such that there are 12 million people who leave our prisons and jails each year. So we are really talking about a huge order of magnitude. And though the estimates were higher about a decade ago, where 1 in 4 people transition through our criminal justice system each year, there's still a significant proportion, 1 in 6. And it represents a lot of people as part of the 1.1 million people living with HIV in this country. In other places where I work, that proportion is higher, such as in Ukraine and in Malaysia, where we have ongoing problems. Contributing to this increase in growth in the criminal justice system domestically, we had the trans-institutionalization of patients with mental illness, basically releasing from our mental health centers into communities, and the prisons became the repositories for people with ongoing mental illness. You add on to that the sort of array that was really from the late 60s and early 70s. In the early 80s, we began, not we, the collective we, but the we over in Washington, began its war on drugs, where there was a sort of an increased amount of incarceration of people with substance use disorders, and those substance use disorders being chronic and relapsing medical conditions. So we're looking so far at least 2 chronic relapsing medical conditions which are treatable and can be treated effectively in our community settings, but once again the sort of interface or the syndemic with the criminal justice system is inextricably linked, but is contributing to this increase in growth. And then of course when you have 2 sort of chronic and relapsing conditions, both of which are associated with increased risk-taking behaviors and increased prevalence of a number of infectious diseases, you see a concentration of HIV and a number of other chronic conditions such as viral hepatitis, tuberculosis, and STIs, which go into and out of our criminal justice system. So to really put this into place, we have this sort of cyclical and interrelated effect, where you have all of these sorts of convergence of these disorders, and within our communities we have this underlying factor of social instability, and that can be defined really quite broadly, whether it's part of our group who's looking at homelessness, if it's Jamie Meyer who's looking at the impact of interpersonal violence, and a number of these other factors which destabilize people's lives and which contribute independently to ongoing problems with mental illness, such as the case of interpersonal violence and post-traumatic stress disorder, homelessness, and sort of relapse to drug use. It's really not so important to really identify whether it's the chicken or the egg, but to really recognize that these things must be addressed in a synergistic sort of approach, and that just tackling one piece of the puzzle is insufficient. And then of course the way that we begin to think about such interventions really have to be not only at the individual level, such as the individual with mental illness and addressing that mental illness, but we have to have systems of care. Within our settings, we have to have community-based interventions that are broad and wide, whether they are public information or otherwise. And then, of course, we've got to have the sort of link with the criminal justice system in order to make all of these issues come together. Now, I mentioned briefly that The proportion of patients with HIV who transitioned through the criminal justice system, at least in 1997, represented 1 out of 4 individuals. Let me just give you a sense of what proportion of patients with other sorts of diseases go through, such as hepatitis C, where 2 out of 5 individuals with hepatitis C among the 5 million people in the U.S. go through the criminal justice system, and the same proportion of individuals with tuberculosis go into the system. So these are really important places to not only to identify, to begin the treatment, and to really provide ongoing care. As mentioned before, the proportion with HIV who go through has been slightly reduced. Now, one of the problems that we have from a societal perspective is we really think of these individuals in criminal justice settings as being out of sight and out of mind, and as though that they are not dynamic with our community. But if you really want to think about this from a biological perspective, think about these as semi-permeable membranes where people cycle into and out, almost like osmosis, but there's a concentration. So if you've got, let's say, this concentrating effect of these infectious diseases within the criminal justice system, and among that there's 12 million people who are being relapsed, there is this revolving door so that there are these concentrations. These may indeed be sites where if you identify them and you begin the treatment, it's the place at which you can begin the interventions that reduce the likelihood of not only returning back to prisons, but sustaining these health outcomes, because many of the individuals who come into these settings are unlikely to access a number of health services and important interventions while they are in community settings because of, indeed, their ongoing untreated or even undiagnosed mental illness or untreated substance use disorders. I also want to say that there are a number of other factors that are going to be syndemic with this that are not infection related that must be addressed as well, that are semi-permeable. Now, in the case of HIV, it is absolutely critical to think about, and I think that this is but one paradigm, but probably not a bad one, and that is HRSA's defined continuum of HIV care. And what this really suggests that not only do individuals have to be identified for their HIV infection, so they have to basically be tested, they have to be told, that is, they have to come back for testing. Of course, rapid testing reduces the likelihood of not knowing that sort of information. They have to be linked to care. They have to be retained in care ultimately so that they are fully engaged. That will allow them to be monitored. That allows them to actually initiate antiretroviral therapy in a timely manner. And it also requires that they be adherent to their antiretroviral therapy so that we can ultimately achieve viral suppression. And in idealized models from the World Health Organization or in empiric models from Vancouver and British Columbia, we certainly have learned that part of the seek, test, and treat strategy of getting at least a certain proportion of individuals in a modeling paper by Gardner, or whether it's Julio Montana's model in Vancouver with 30%, Gardner's model of 60%, and Rubin's model from the World Health Organization. At varying different levels, we need to achieve viral suppression at the 30, 60, or 90% level overall. So much, much higher. So how well do we do in this country? We don't do so well. We have about 19% of individuals who have viral suppression. And it's important to recognize that the presence of inadequately treated substance use disorders and mental health independently interrupt each and every one of these cycles with regard to engaging and retaining individuals in care. Now, while we're not going to spend a lot of time talking about the issues around entry, what can you do to routinely test and diagnose a number of conditions, which part of the criminal justice setting, there'll be a quiz on which parts there are in a second. And then the provision of treatment in those settings. The sort of piece that I want to focus on is this sort of release or transitional issues, such as adherence to antiretroviral therapy, adherence to substance use disorder treatments and mental illness, and to examine some of the risk reduction and linkage strategies in general. So for those of you who kind of want the sort of Reader's Digest version, Sandy Springer is the lead author on a paper that we published which looked at 5 essential components which really sort of address a number of these things. It provides the evidence for what's out there, but also really identifies where there are significant missing gaps. Now, when we are thinking about implementing an intervention, it's important to recognize that the criminal justice system is not just the criminal justice system. It is this incredibly complicated array, and the sorts of things that one can do, let's say for instance at drug courts or at courts, is very different than what you can do with a prisoner who may have 2 to 3 years left on their sentence, where you can begin to implement and sustain and repeat and do sorts of things. And so what you can do in various different settings is quite different. So briefer interventions for some settings, more intensive or more connective ones. But the piece about transition is really about how do you sustain them in communities no matter where you identify them. And so that's kind of the sort of underlying piece. I'm going to start first with talking about prisons. Prisons are typically places where people are sentenced for at least 1 to 2 years, so you've got a bit of time to work with them. And one of the things that we know from the prison-related data is that just 15 years ago, the sort of age-related mortality or death associated with HIV in the prisons was over 3 times greater among prisoners and in the general community. And part of that had to be issues around access to antiretroviral therapy and provision of evidence-based treatments. In fact, I was part of that movement 15 years ago to make those sorts of changes. But by 2008, and so we've got, effective therapies that work, that the sort of ability to reduce mortality was really equilibrated in the prisons. So I would say that in many ways the prisons have done a fairly good job at implementing what I would call the evidence basis for treating at least HIV. Now, of course, these are idealized situations. You can provide directly observed therapy in these settings. It's incredibly structured. You can identify who's going to come into your appointments. There's not the sort of community exigencies. There's not the sort of ongoing unaddressed substance use disorders. I don't really call it that they treat the substance use disorders. It's called forced abstinence. But nonetheless, it's not mitigating the lives of individuals and interrupting their care. So in general, you can see that at least among these individuals who have high prevalence of substance use disorders and mental illness, you can at least achieve parity. But then the problem is what happens to individuals during incarceration where you can achieve these benefits, and then what happens to them soon after release. In a study that we did that was led by Sandy Springer, she really demonstrated that for individuals who had received antiretroviral therapy for at least 6 months, there was a markedly significant reduction in viral load, which is what you want to do. You want to suppress the virus. And then there was an increase in CD4 cell count. But within 3 months or 12 weeks after release, and this is an important time period, you find that essentially all of the benefits that had happened that had during the course of incarceration, where you have this incredible structure, were completely lost. And so if one wants to think about this in terms of framing it in a slightly different way, we looked at individuals who had, at the time of release from prison, 3 out of 5 individuals had a suppressed viral load. So in other words, and this was in 2004, this was consistent with what we were finding in community settings. So once again, the prison was doing pretty good in terms of its grade card. But within 3 months, only 1 out of 5 had a non-detectable viral load or maximal suppression, suggesting one of 2 things: that they were either, 1, being incompletely adherent to therapy, or they were not being retained in care. In other words, they were lost completely. Now, there's a number of factors that people have looked at in terms of what might have an impact. In a series of studies that was done by Kinloch and others in Maryland, they really tried to study, and this is not in patients with HIV, by the way, but they looked at individuals who were within this prison setting who had opioid dependence, and they looked at a number of outcomes, and they randomized them to either just get counseling that you should reduce your drug use. They would either kind of add to that, they would get counseling, and then they would get transferred. They'd get a voucher and says, okay, you can go to a methadone program when you get out, and you get in. Now, of course, there may be some problems with that. There's all of the sorts of things that happen as people leave the prison. On the first day of prison release, you think, well, what do people do? They're going to run out and they're going to get their HIV care, they're going to get their substance use treatment and things like that. And the answer is no. They're going to get a McDonald's Big Mac and get laid. And so when you think about the sort of priorities that people have as they're kind of leaving prison, and whether methadone is somewhere on those sort of hierarchy of needs, it's somewhat lower. But for the individuals who started the treatment and got a transfer upon release, so they started their treatment of methadone, you can see that in terms of being retained in treatment, it's significantly higher. The proportion who entered treatment overall and who completed treatment was significantly different. Now, this 1-year completion rate is somewhat lower than we would like to see because it's lower than what we see in community settings in terms of being retained on methadone treatment. And there's a number of other factors that may go into this, and that if you're thinking about slowly getting an opioid agonist on board, getting them up to what I would call a therapeutic dose within a time frame, there was insufficient time to get them to levels, and I'll speak a little bit more to that in just a second. What I will say, however, among these individuals is that there were 8 deaths among the 204 patients in this study. 6 of them were due to overdose. And these are in non-HIV infected patients, but you can imagine the interface with HIV and substance use disorders is high. And 2 of them were cardiovascular. There were none in the patients who were on methadone, so methadone was markedly protective of overdose and death in these individuals. So getting to the point of why the retention rate was so low at 36.7%, Jeff Wickersham from our group in a study that we're doing in Malaysia evaluated data from a pilot methadone program where we put patients on methadone up to 6 months before release. They could be as early as 3 months, and you can increase by about 5 milligrams a week. So you can imagine you can get to different therapeutic levels of methadone by the time that you're released. And if you stratify based upon the evidence for effective treatment with methadone by getting doses of 80 milligrams or more, or a lower dose of methadone, you can see that the retention in methadone drops off almost immediately and is significantly different. So that the levels are actually somewhat even lower than that 36% that you see in the Kinlock study among the individuals who had lower doses of methadone. But overall, if you average that out, you get it at about the 45% range, not that different than the 36% range. So overall, the idea is that you may have to start earlier, getting them up to therapeutic levels before you transition them to the community. Now, those are data among prisoners in whom you have a little bit more time to begin to work with. And so in a 10-site study that was funded by HRSA to examine community models of transitional programs for HIV-infected jail detainees. We're one of the 10 sites that's looking at this, but among the multi-site study, there are about 1,270 HIV-infected individuals who are who are enrolled in the study. We excluded individuals who were reincarcerated or who were sentenced to prison. So in other words, they didn't have the chance of getting out into the community. And so this still leaves well over 800 individuals. And what we wanted to look at is we wanted to look at differing measures of retention in care, because remember, as I pointed out along the HIV continuum of care model, it is required that a person be retained in care so that they can be monitored and then eventually get antiretroviral therapy. And what we did was we defined as retention in care is having an HIV visit that was linked to having a viral load test. And that's one of the things that we expect HIV providers to do whenever you see someone and monitor them for their HIV disease. And as you can see right off the bat, 2 out of 5 individuals are completely lost to care. And we'll take a look at some of the sort of correlates of that particular group, because the correlates for that group associated with lost to care completely is really having untreated substance use disorders, alcohol use disorders, mostly opioids, interestingly enough, and also having untreated mental illness. We then looked at 3 other measures of retention. Early retention, that is, they had a doctor's visit and a viral load within the first quarter after release. Delayed retention was we lost him for a while, but we eventually got him back in. And then we looked at sustained retention, which is basically monitoring every 3 months, and that is the group who about 1 out of 3 individuals. And at least among the idealized situation where we want to have patients, it's this sort of sustained retention in care. And the independent correlates of being retained in care for 6 months included being of male gender, not relapsing to drugs or alcohol during that time period, receiving a pre-release planning program. So in other words, to say these are the things that you need and these are how you go get it. But they didn't actually do anything after release. And then also getting a post-release disease management session. And so by definition, this group at least had to get seen afterwards. But remember, we lose 40% overall, and they're slightly different. So whether it's prison or jails, it's really important. I talked about the hamburger and getting laid on the day of release. What ends up happening is despite the best laid intentions of identifying what all of the things are, real life unfortunately gets in the way, whether it's studying for your exams or all of these other sorts of things. Let's see, it's Friday night and it's margarita party or whatever it is. These sorts of things all interfere in the sort of decision making. And so what ends up happening for many individuals is that they are derailed from getting this sort of linkage to care. The first sort of derailment occurs with this incredibly high risk of death of former inmates. Ingrid Binswanger, who was formerly at Washington, who's now at the University of Colorado, looked at statewide data, which showed that the overall mortality was 3.5 times higher for released prisoners than the general population. And she looked at the mortality at 1 year after release, but the mortality was highest. That is 12.5 times higher, not 3.5 times higher, in the first 2 weeks post-release. And so this is where relapse is the highest. So you can imagine, like, just getting to your HIV appointment when you relapse to drugs and alcohol is going to certainly interfere with that. And the increased mortality was associated with a handful of conditions: overdose, being HIV infected, homicide, being in a motor vehicle accident, maybe perhaps under the influence of alcohol or drugs, having cancer, and having liver disease. And HIV, having a substance use disorder, and liver disease are all independently concentrated among the criminal justice system. Well, just not to say that Washington is different. In a meta-analysis of 6 different studies, both domestic and international studies, drug-related deaths accounted for 50% of deaths overall. And once again, it confirmed in the meta-analysis that the highest risk of death was within the first 2 weeks, so confirming Ingrid's findings, which really, and most of these deaths are related to opioids. And so these are really the only ones that really cause overdose and death. So it really has important implications for medication-assisted therapy among prisoners transitioning to the community in the same way that the Kinloch data that I presented earlier was protective of death among release programs. So some of the factors that have been examined over the course of years looking at what might be contributing to these sort of poor HIV treatment outcomes. Jody Rich identified that the loss of medication or medical entitlements when one comes into prison or jail contributes to it, and there's usually a delayed process. In fact, it's almost perverse. In 39 out of our 50 states currently, that if you get incarcerated for more than 30 days, the Department of Social Services will pay the Department of Correction $400 to give them the names so that they will take you off of the Social Security rolls so that you can be disenrolled from your insurance. And so if you're in for 31 days, you get removed from these rolls, and it requires oftentimes 6 to 8 weeks to get reinstated. And since most of our patients with HIV are getting their sort of medical entitlements through the public domain, these are individuals who have to go back through that process in order to get reinstated. And that includes for our AIDS drug assistance program whatsoever. The next step is they need to get a medical appointment and a prescription to continue their medications. Oftentimes there are waiting lists in our HIV clinics in order to do that, and you're oftentimes released with only a 2-week supply of medication, if anything at all. There are issues around adherence and retention and care that impede that outcome. And then, of course, more recently, how can you intervene in order to really sustain viral suppression through adherence interventions? So we saw with the jail study that that actually having a pre-release discharge planning was actually one of the significant factors associated with sustained retention in care. However, in another study looking at what they call strengths-based case management, and I'm always a little anxious when I use the word case management because I'm not really sure I know what it means. Everybody uses a term for it, and it means 100 different things to 100 different people, even though you have a construct, because every case manager who does this job typically does it well, but they have their own ideas about the way that they do that. And we try to define it, and we try to make it, sort of structured, but people's lives are not so structured, so people do what they want. But compared to no discharge planning, data have really demonstrated that results in higher receipt of first HIV appointment, but not in sort of retention and care. And so we really have to figure out ways that it might impact continuous engagement and a number of HIV treatment outcomes. But in a study from North Carolina where they used the strengths-based case management versus the standard of care, which was a pre-release sort of meeting saying, these are what your unmet needs are, this is what you need to do, here's the place that you go. They really found that with regard to the proportion who was not in medical care, over time, it was actually no different than having a group of individuals, and this was actually post-release transitional care versus the standard of care, which was the pre-release meeting. It had no impact or doing anything different. Now, they published these data, but the people who actually did the study said, you know, one of the problems that their community-based case managers had was they said, so we sent them out and we identified that they had needs A through Z, but there were not the sort of community resources that were available, so this sort of enabling resources that are required to get people into substance abuse treatment. They had no treatment actually for cocaine, which was their primary drug there, so that these individuals had no difference with regard to do it. So they could actually do and say, you need to get an appointment here, you need to get an appointment here, but you don't have the insurance, and there was really not anything for them to do. So they were kind of struck by the sort of inability to have this sort of enabling resources in the community. There were a number of other outcomes that were examined with regard to follow-up visits in which there was no difference, emergency room use, and reincarceration. So at 12 months, 1 out of 3 individuals were reincarcerated. In a study that was done from the great state of Texas, and I'll take that back, just the state of Texas, they actually looked at, it's got one of the largest HIV-infected populations whatsoever. They actually looked at over 2,000 individuals who were released. They had a sort of computerized ADAP program where you could get you got a 10-day supply of medications as you are released. And then you could go and access antiretroviral therapy if you were able to get to one of the selected pharmacies that was on the list. So you would say, well, gosh, these people are doing relatively well within prisons, and so they would be highly motivated in order to get therapy. It was slightly complicated that if you think about it, they're going to run out of medications within 10 days, so they've got kind of this 10-day window kind of ticking away in order to get their medications, but only 1 out of 20 individuals actually got their medications refilled within that time. So then you say, okay, they're going to be off medications for at least 20 days. Well, only 1 out of 5 individuals and 1 out of 3 individuals had gotten their medications refilled within 60 days. Now, what they did show in a secondary analysis was that for the individuals who got case management services after release, they were 3 times more likely to access their antiretroviral therapy because the case managers can help them through this incredibly complex system of finding the right pharmacy in order to get their medications. So once again, this community sort of connection is absolutely critical. And so the best laid things on paper don't necessarily translate to people actually utilizing them because the systems are complicated. It looked beautiful on paper. The plan looked beautiful on paper, but the reality was people would get out, they didn't know where to do it, the piece of paper had been removed from them, they got released at court, their paperwork was taken away. So let's talk a little bit about how might the relapse to drug and alcohol use actually have an impact on a number of these sort of outcomes. We recently finished a randomized controlled trial we had demonstrated a few years ago, and it's one of the evidence-based adherence interventions that directly administered antiretroviral therapy is an effective intervention for individuals with substance use disorders. And we thought about this, that HIV-infected prisoners have high rates of substance use disorders, and can we sustain the benefit after release from prison by putting them on directly observed therapy to really transition them back to the community? And we compared that to them just getting a 14-day supply and transitional case management as part of this. The DART, or the directly observed therapy, was provided once daily, 7 days per week. Because we recognized that our patients did not come with a single disorder, they often had mental illness, hypertension, and an array of other things. All of their prescriptions for other chronic conditions were also co-administered at the same time. And then we nested within this study individuals who met pre-incarceration diagnosis for opioid dependence. That is, they had had a diagnosis of opioid dependence when they came in, recognizing that overdose and death was incredibly high for these individuals, and so we offered it to them on the day of release as part of their relapse prevention. All subjects received standard case management services across the board. That was universally applied, and there's no difference. We eventually enrolled 154 subjects, which we randomized 2-to-1 to the DOT over the self-administered therapy. We randomized a higher proportion to the DOT because we were concerned that there may be a group of individuals who did not want people butting into their life. As it turns out, there were not very many people who were unwilling to participate, and we had a retention rate that exceeded 85%. So we did very, very well with regard to following these individuals. As you can see, this is a fairly ill population with regard to other comorbidities. About 60% overall met criteria for opioid dependence, 90% met criteria for cocaine abuse or dependence, and about 33% overall met criteria for alcohol dependence. Almost half of the individuals met criteria using the mini for having an Axis I disorder. They did a good job in prison. 80% had a non-detectable viral load by the time that they released. So it's even higher than it was in 2004. And I think part of that may be that we've got better simplified regimens with which patients can take. And the CD4 count was relatively restored at 350 to 400 in cells. So they were leaving in fairly good shape, but they had a lot of comorbidity that they were at risk for relapsing. And what you can see using a couple of different measures for outcome, what we call viral suppression at less than 400 copies or maximal viral suppression at less than 50, there was a significant difference in individuals in the DOT group versus the SAT. And remember, about 80% had a non-detectable viral load. At the time of release, it is essentially unchanged at 6 months for the less than 400 copies. And that was similarly true at the less than 50 copies. These patients were maximally suppressed at the time of leaving. Their CD4 cell count was at a plateau, so we didn't really expect much of a difference. So there's a non-significant difference with regard to T cells, which are actually also much more highly variable. So the question is does the intervention work? And the answer is yes. What we are still analyzing the data to figure out is the benefit sustained when we discontinue it? And one of the things that we learned about our community-based intervention was that it worked as long as you did the intervention, but afterwards it did not. What we did in this study is we built a transitional program where we trained individuals to fill their own pill boxes, and we're hoping when we look at the 12-month outcomes or the 6-month post-intervention outcomes that we actually have a sustained benefit, but those data are not available. When we want to take a look at the correlates of achieving the primary outcome or dependent variable of having a viral suppression at less than 400 copies, being on directly observed therapy portended a threefold increased likelihood of having a non-detectable viral load. Individuals who started out with suppressed virus, irrespective of their arms, were 5 times more likely to sustain their viral load, suggesting that whatever they were able to do in prison or jail, they were able to hold it together afterwards. So they were really kind of maximizing their viral suppression by probably being a little bit more adherent. If they had an alcohol use disorder, however, it portended about a 64% decreased likelihood in achieving viral suppression. And then, of course, individuals who were prescribed buprenorphine and stayed on it for 6 months were 3.5 times more likely to kind of achieve viral suppression. So it has not only implications for the treatment of alcohol use disorders, but that there is a benefit from using an evidence-based treatment for opioid dependence in terms of reducing the likelihood of not achieving a viral suppression. So it's the notion that treating the substance use disorder itself is an effective way at improving the viral load outcome. So you've got the intervention of DOT, which is independent, and the treatment of a substance use disorder as being independent factors associated with a positive outcome, and the non-treatment of another alcohol use disorder as being a negative correlate. So it has really incredible implications. And I just want to point out that what we do have that's available and that is part of our evidence for the treatment of opioid dependence includes the methadone, which we saw from the Kinloch study. I'm going to show you a little bit of data, and our data on buprenorphine as a partial opioid agonist and antagonist, and then some new implications for long-acting or extended-release naltrexone, which is a pure opioid antagonist. And the reason why this naltrexone has some interesting implications for the future, because a lot of these patients have alcohol use disorders and opioid dependence, is that this injectable naltrexone has evidence for being the most effective treatment for alcohol use disorders. So in patients who've got two disorders, you can potentially attack it with one single injection once a month. And so I think that in terms of the armamentarium of what we have out there, we might be able to simplify it for a handful of patients. And that's one of the things that we're beginning to look at in places such as Eastern Europe, where everybody who uses opioids also has a drinking problem, and we can potentially treat, kill two birds with one stone, as it were. So here are some data from the community, which we first applied to see what we could figure out with regard to treating the opioid dependence in the setting of HIV. And this is a multi-site study of nearly 300 HIV-infected patients who started buprenorphine at 10 clinical sites. There's nothing magical about 10. That's just what HRSA seems to fund in the other sort of study. And we found that buprenorphine treatment increased the likelihood of not only initiating antiretroviral therapy and improving the CD4 cell count, but interestingly enough, did not have any impact on viral suppression. And part of that reason was that over 60% of patients were already on antiretroviral therapy and doing relatively well, so that we weren't really able, among 300 patients, to see much of a difference among that other group. We then stratified the analyses based upon those who were on and not on antiretroviral therapy at baseline. And not being on antiretroviral therapy was associated with being younger, having alcohol use problems, being homeless, having a higher viral load, and reporting increased risk behaviors, really suggesting the importance of coming up with interventions that focuses on these most challenging individuals in the community. And what we did was, when we stratified this, is we said, all right, what it probably takes from a clinical perspective is that a clinician has got to be comfortable that they're actually taking care of their substance use disorder before they initiate their antiretroviral therapy, because they're concerned up front because of adherence problems. And it's been demonstrated in a number of studies that if you're actively using drugs or alcohol, you're less likely to take your antiretroviral therapy perfectly. And so what you can see is that for individuals who were retained on buprenorphine for 3 or 4 quarters, somewhere over 6 months period of time, you were significantly more likely to get onto antiretroviral therapy. And for the first time, we began to see a sort of a viral suppression among the people who were not on antiretroviral therapy achieve parity with the group who was already on before. So what it's really doing in terms of its driving its outcome is it's driving its outcome among the individuals who were not on antiretroviral therapy, and then the achievement of viral suppression is similar once you can keep a person on buprenorphine for longer. So retention on treatment is not just getting the treatment, but being retained on the substance abuse treatment is really quite critical. Now, these studies were going on in parallel, but the sort of idea was sort of percolating. And in an R21 that we did, that was the nested study within our DOT study, we wanted to assess the acceptability and the feasibility of initiating buprenorphine in patients who had not used drugs for years as they were transitioning to the community. What we did was we created the first protocol for buprenorphine induction that occurred on the day of release, and that we could actually enroll them up to 30 days after release. And these standardized protocols were set up for those who were on DOT and not on DOT, so that they would either get them once a day observed or weekly. And the data from the first 12 weeks, and this is, remember, as I pointed out earlier on, this is the critical time after release where patients begin to fall apart. And what you can see here is that, that despite the fact that patients had been incarcerated for quite some time, years in some cases, their craving for opioids was actually quite high. It was a 6. So they've not had access to opioids. I mean, yes, there's a few patients in prison who have access to opioids. If you happen to be in Ukraine, there's a high proportion of your patients who've had access to opioids. But what we found was that within 3 days of starting the buprenorphine, this craving response, and Sandy Springer is leading this sort of move, but is it the craving that's driving the relapse? And can you use that as your sort of marker? We haven't figured that out yet, and that's part of her ongoing sort of work. But it reduced the craving within 3 days from an average of 6 to 1. We were able, because these patients were not dependent, to get by with lower doses of buprenorphine, 9 milligrams instead of the standard 16 milligrams. Of course, anytime you enroll someone in a study and you're nice to them, they have high satisfaction, not surprising. But the retention rate at 12 weeks was 74%. But then let's translate that. And this was irrespective of whether they got DOT or self-administered therapy. The proportion of patients who had a non-detectable viral load was equivalent, suggesting that if you treat their substance use disorder during this time period, that it's actually effective at them continuing to take their medications, and it was not dependent upon whether they got DOT or not. And of course, their T cells remained quite good. Now, these data have been expanded. Sandy has a paper under review looking beyond that 12-week mark. And what you see are data that are pretty similar to what you see in community-based buprenorphine programs at about 6 months. Retention's about 50%. So that's what you get, and that's what we got. So we feel as though at least there's some sort of face validity. And then we took a look at these 100 or so, it's just a little under 100 individuals, and we looked at the independent correlates of having maximum viral suppression at 6 months. And lo and behold, at least among the individuals who met criteria for opioid dependence, the DOT wasn't even significant at all. So that's probably not what you need. What we did find was that if you were able to retain them on buprenorphine, it resulted in over a 5-fold increased likelihood of having maximum viral suppression. Men had an easier go of it as well. Being of African American or being a black race unfortunately resulted in about an 86% reduction in likelihood of being sustained. There was no difference in the multivariate analysis if you were of Hispanic ethnicity. The months of incarceration really was borderline significant if you were virally suppressed at the time of release. Once again, that's independent. And then, of course, individuals on the physical composite of the quality of life module, the SF-12, those individuals were 2 times more likely to have a non-detectable viral load. So there's an array of other sort of factors suggesting that we need to do a better job at coming up with the outcome. I will say that most of our sort of DOT outreach workers, we did have one woman who was part of that. We had a number of Latino men, and so that may actually in some way reflect the differences in terms of how people related to each other culturally. So what do we have that's on the docket that we're actually studying right now to figure out whether we can find we can actually fill in some of the gaps and some of the holes? So we showed that having an alcohol use disorder resulted in a 64% decreased likelihood of an HIV treatment outcome. We're using the same population and conducting a randomized placebo-controlled trial of extended release naltrexone for individuals with HIV and who have alcohol use disorders. We are doing a similar study in Connecticut and in Massachusetts among individuals with HIV and who have opioid dependence. Ultimately, we'd like to put in a protocol in Ukraine to do that, who have both disorders. We have moved the study outside of the prison and jail release, and we're doing a randomized controlled trial. And I put extended release naltrexone for opioid dependence in community corrections, but that's wrong. It's actually buprenorphine. In that particular group, we have a randomized controlled trial of methadone plus or minus a behavioral intervention, HHRP, which is the Holistic Health Recovery Project that we have adapted for Malaysia. And you saw some of the preliminary data from the dose of methadone in that study. We're almost at 200 individuals enrolled in that study. And then we are about to initiate the first pilot study of medication-assisted therapy among prisoners with opioid dependence in Ukraine, and to do similar sorts of studies with regard to individuals who have tuberculosis, including multi-drug resistant tuberculosis, who are transitioning to the community. And we are also examining the use of extended release naltrexone in terms of how you organize services in Russia. We have a randomized controlled trial where we are, the sort of systems of care is not it's different and it's the same. In Russia, where you have individuals who cannot get access to any sort of substitution therapy like buprenorphine or methadone, the one medication-assisted therapy that they do have available there is naltrexone. And we're studying if the place that you give the therapy, if you integrate it, does it actually have an impact? And we have 3 study arms in this particular study. We're looking at whether you take a person who is now abstinent, they've gone through detox, and they get injectable naltrexone, and then they continue to get their injectable naltrexone from their HIV doctors in the HIV clinic. So it's co-located. They're getting everything at one site. Or if you just treat their substance use disorder and say, hey, go across town and get your HIV care, does that result in the same sort of outcome? Or the sort of standard of care, because medication-assisted therapy is not part of the routine standard of care in Russia. It's about abstinence-based counseling therapy only, and we're studying that with referral to the HIV center as well. So those are our current projects that are underway. This is sort of a framework for thinking about individuals that the older environment, if you will, where they're kind of walking, and that's supposed to be somebody walking the proverbial tightrope, where their life is chaotic and somewhat disturbed. They kind of land in prison, which is this artificial environment where they get basic needs. I won't say that they're good, but they do get food. I call it the 1 pound a day place. Everybody who gets incarcerated gains a pound a day, including the doctors who go there. And they get shelter, so they're off the streets. Not that it's nice shelter. In fact, when you feel those gates closing behind you, it's not the sort of sound that one likes. And then in some cases, people actually say they feel safer. And you know, it's really a sad state of our sort of community system where people say that they go to prison in order to feel safe again so that they can take care of their sort of health needs. But for many people, it's not safe. There are gangs and there are other sorts of things. There's exposure to tuberculosis. But it's a place where you can begin to provide psychiatric care, medical care, antiretroviral therapy. You can create behavioral interventions. But the key feature with this is transitioning this as they transition to the community, because without doing that, we are going to have the continued revolving door. What I think we have to do is we have to think more broadly, because one of the things that none of us do is we think about a jail, we think about a prison, but we don't think about this sort of complexity of criminal justice as individuals leave jail and maybe go to probation, or leave prison and maybe go to parole, or we're trying to divert people out of prison and jail and putting them into alternatives to incarceration, etc. But how do we link the criminal justice with our community supervision and our systems of care in communities? And I think that that is sort of the mixed level of thinking that the next generation of questions are going to need to do. And so the extent to which we have to think about this is a very holistic sort of approach. And what are all of the sorts of things that people are facing as they slip off this slippery slope? Issues such as homelessness, relapse to drugs, Sometimes we think of families as being very stabilizing and helpful. I have many patients who tell us that their families are part of their relapse to drug use, their untreated, undiagnosed mental illness, intimate partner violence, overdose, and of course the HIV risk behaviors, which are going to result in increased transmission to communities. And if we don't get this right, we are going to perpetuate this incredible revolving door, this sort of industrial complex of the criminal justice system, which is really unabated at this point. We have shown for the first time that the number of people in prison and jail finally did decrease in 2009, but it's flattening out just a little bit, and we have to do more in order to beef up our communities in order to address the incredibly complex needs of the most vulnerable people who were living with HIV.